Mechanical ventilation. Please turn in your book to page 517 in Lewis and take a look at diagram 2612. In table 2612, you can see the lung volumes and capacities. These will be terms that you want to familiarize yourself with prior to going through the PowerPoint. Also on page 1705, you'll see the settings for mechanical ventilation. Mechanical ventilation is a process by which FiO2 at above or equal to 21%, which is what room air, is moved into and out of the lungs by mechanical ventilation. Indications for mechanical ventilation are apnea, impending inability to breathe. So if a patient is in respiratory distress and starting to wear out, acute respiratory failure, severe hypoxia, and respiratory muscle fatigue. Settings for mechanical ventilators can be used to regulate the rate, depth, and other characteristics of ventilation such as tidal volume. Based on a patient's status, their ABGs, their body weight, their level of consciousness, and their muscle strength, the practitioner will decide what the ventilator setting should be. The ventilator is tuned to match the patient's ventilatory pattern. Types of mechanical ventilation. Negative pressure ventilation, which uses the chambers that encase the chest and body and surround it. This is where negative pressure is used. An example of that is when they used what was called the iron lung. Here's a picture of a negative pressure ventilator. It was available for home use. It opens up the chest wall, draws in air, and causes a negative pressure. These machines were big and made exams and assessments on patients almost impossible. Here you can see you can really only assess her face and her hands. Types of mechanical ventilation. Positive pressure ventilation. It's used primarily in acutely ill patients. It pushes air into the lungs under positive pressure during inspiration, and expiration occurs passively. Now, this is a patient who is intubated and on a mechanical ventilator. Here's a patient that's getting positive pressure ventilation. Again, positive pressure ventilation, we're forcing the air in from the inside, and it's much easier to use. It makes it so we can assess our patients completely. Modes of PPV, we have volume ventilation. It's a predetermined tidal volume delivered with each inspiration. The amount of pressure needed to deliver each breath will vary based on the patient's lung compliance and resistance factors of the patient ventilator system. Pressure ventilation, there's a predetermined peak inspiratory pressure. The tidal volume is delivered will vary based on an elected pressure and compliance and resistance factors from the patient ventilator system. We have to pay special attention to the tidal volume to prevent hyper and hypoventilation. If the peak inspiratory pressure is set too high, it does make our patients prone to a pneumothorax. The modes of volume of ventilation, so the mode and the setting that we choose to set our ventilator on is going to be based on how much of the work of breathing our patient can perform on their own, and it's determined by the patient's ventilatory status, their respiratory drive, and their ABGs. So the goal is that if our patient can do some of the work, we want them to do some of the work so that it keeps the muscle tone, their chest muscles toned and able to do some of the work of breathing on their own, but we don't want to put them in a situation where they're doing so much of the work that they're fatigued and they're hypoventilating. We have a controlled mandatory ventilation. This is when it delivers a breath at a set rate per minute and a set tidal volume. This is independent of the patient's ventilatory efforts. In this case, the ventilator is doing all of the work, and the patient performs no work of breathing and cannot adjust respirations to meet the changing demands. Assisted control ventilation. This type of ventilation is often used with our ARDS patients. They can breathe on their own, or they have to be able to breathe on their own. These patients can be Guillain-Barré syndrome, pulmonary edema, acute respiratory failure. It does deliver a preset tidal volume at a preset frequency, and when the patient initiates a spontaneous breath, the preset tidal volume is delivered. The patient can breathe faster, but it does not allow them to breathe slower, so it won't allow them to hypoventilate, and it allows the patient some control over ventilation. We do need to use continuous assessment and monitoring to ensure good ventilatory status. So we want to check their respiratory rate, their ABGs, their SpO2. Patients may have an increase in work of breathing if the patient is having difficulty initiating breaths, so we have to make sure that we have it set appropriately. The patient may tire or develop what's called ventilator asynchrony. So this is when the patient, you'll hear them say the patient's fighting the ventilator. Synchronized intermittent mandatory ventilation. This setting delivers a preset tidal volume, a preset frequency in synchrony with the patient's spontaneous breathing. In between what the ventilator does, the patient is able to breathe. There's a preset FiO2, but self-regulates the rate and the volume. The benefits are that we have a decrease in muscle atrophy, and the patient, now with this, the patient must have some spontaneous breathing. It is often used during the weaning process. Modes of pressure ventilation. Pressure support ventilation, PSV, there's a positive pressure applied to the airway only during inspiration. It's used in conjunction with spontaneous respirations. Patients must be able to initiate a breath. There's a preset level of positive airway pressure selected, so the gas flow rate is less than a patient's inspiratory flow rate. Modes for pressure ventilation, we have PSV. The advantages are the patient's more comfortable, they have a decreased work of breathing, there's a decrease in oxygen consumption, and an increase in endurance conditioning of the lungs. PCIRV, the pressure-controlled inverse ratio ventilation. This combines a pressure-limited ventilation with an inverse ratio of inspiration to expiration. A normal IE is 1 to 2. It can progress to be as much as 4 to 1. It progressively expands collapsed alveoli and has a PEEP-like effect. This does require sedation and usually paralysis. This is used for patients with ARDS, continuing refractory hypoxemia despite high levels of PEEP. We also have what's called PEEP, the positive end expiratory pressure. This maintains or improves oxygenation while limiting the risk of oxygen toxicity. The goal is to decrease the FiO2. Positive pressure is applied to the airway during exhalation. The lung volume is higher during exhale than normal, and there's an increase in aeration of the alveoli. It's used in lungs with diffuse disease, severe hypoxemia, or loss of compliance or stiffness of the lungs. CPAP. Our continuous positive airway pressure, the pressure delivered continuously during spontaneous breathing. It prevents the airway pressure from falling to zero. It's often used for sleep apnea. It does increase our work of breathing because the patient must forcefully exhale against the constant pressure. BiPAP, there's 2 levels of positive pressure support, high inspiratory positive airway pressure and a lower expiratory positive airway pressure along with oxygen. It is non-invasive. BiPAP is delivered through a tight-fitting mask, a nasal mask, or a nasal pillow. Patients must breathe spontaneously and cooperate. It's indicated for acute respiratory failure with COPD and heart failure, and for sleep apnea. Partial liquid ventilation with perfluorine. Perfluorine is a biocompatible clear odorless liquid that has an affinity for O2 and CO2 and has surfactant-like qualities. It's trickled down the ET tube and into the lungs. The partial liquid ventilation will evaporate quickly and must be replaced to maintain a constant level. We do need to do some additional research to determine the efficacy of the treatment. Prone positioning. We do use prone positioning as we discussed earlier. This is when we're repositioning the patient from supine to a lateral position or to a prone position. The effects of the fluid in the dependent parts of the lungs are reversed because of gravity. So we're going to move that fluid around so different areas of the lung have a chance to expand. It's used as a supportive therapy in critically ill patients and with acute lung injury or ARDS. ECMO. ECMO is an alternative form of pulmonary support. It's commonly used in pediatrics and neonates, although it is being used in adults also. It's kind of a modified cardiopulmonary bypass. What happens is we partially remove blood through the use of large bore catheters, infuse it with oxygen, remove the CO2, and then return the blood back oxygenated. Here we're going to go through the complications of PPV. PPV affects the circulation due to transmission of increased mean airway pressure to the thoracic cavity. You can go through and look at the complications of PPV. Barotrauma is when air can escape into the pleural space from the alveoli and the interstitium, and it accumulates and becomes trapped and causes a pneumothorax. It can become a tension pneumothorax. Patients with compliant lungs are at an increased risk, and chest tubes are sometimes placed prophylactically. Pneumomediastinum. This begins with the rupture of the alveoli and the lung interstitium, progressive air movement into the mediastinum and the subcutaneous neck tissue. It's commonly followed by a pneumothorax. Volutrauma. Volutrauma is relates to the lung injury that occurs when large tidal volumes are used to ventilate non-compliant lungs. It results in alveolar fractures and movement of fluid and proteins into the alveolar space. Alveolar hypoventilation. Causes are inappropriate ventilator settings, leakage of air from the ventilator tubing around the ET tube or the tracheostomy cuff, lung secretions or obstruction, low ventilation perfusion ratios, and it can lead to acidosis and problems related to acidosis. Hypoventilation interventions are to turn the patient every 1 to 2 hours and provide physical therapy to lung areas with increased secretions. So this may be a patient who we're using the chest physiotherapy on. Encourage deep breathing and coughing and suction only as needed. Respiratory alkalosis and alveolar hyperventilation. Ventilator-associated pneumonia. This is pneumonia that occurs 48 hours or more after ET intubation. The clinical evidence that points to ventilator-associated pneumonia is fever or elevated white blood cell count, purulent or odorous sputum, crackles or rhonchi on auscultation, and pulmonary infiltrates on chest x-ray. To prevent ventilator-associated pneumonia, we want the head of bed elevated 30 to 45 degrees unless medically contraindicated, and no routine changes of ventilator circuit tubing. Also, use of an ET tube that allows continuous suctioning or secretions in the subglottic area, drain condensation that collects in the ventilator tubing, wash hands and change gloves in between activities, fluid retention, which occurs after 48 to 72 hours of PPV, especially with PPV with PEEP. This can be due to a decreased cardiac output and results in diminished renal perfusion and release of renin, angiotensin, and aldosterone, so it leads to the sodium and water retention. As part of the stress response, the antidiuretic hormone and cortisol may be elevated. This contributes to sodium and water retention. The neurological symptom in patients with head injury, PPV can impair cerebral blood flow. We want to elevate the head of the bed and keep the patient's head in alignment. That may decrease the effects of the PPV on intracranial pressure. So elevating the head of the bed will decrease the risk of increased intracranial pressure. The GI symptoms are patients on mechanical ventilation are at risk for stress ulcers and GI bleeding. They're also at a risk for translocation of GI bacteria. The decrease in cardiac output can contribute to gut ischemia. Peptic ulcer prophylaxis is histamine receptor blockers, so protein pump inhibitors and tube feedings. This will decrease gastric acidity and decrease the risk of stress ulcers and hemorrhage. Patients on mechanical ventilation are often on Protonix IV drips. We do insert NG and orogastric tubes to decompress the stomach. We have a decreased peristalsis from the immobility, sedation, and circulatory impairment. We also have a decreased oral intake and use of opioid, pain medications, and stress. Our patients can also have constipation. Musculoskeletal system, we have to maintain our muscle strength and prevent problems associated with immobility. Progressive ambulation in patients receiving long-term PPV can be attained without interruption of mechanical ventilation. Patients can perform passive or active exercises, so we want to get physical therapy involved with our patients. This will prevent contractures, pressure ulcers, foot drop, and external rotation of the hips and legs by proper positioning. We also want to be turning our patients on a regular turning schedule, usually every 2 hours. This talks about the psychosocial needs of our patients. We want to provide physical and emotional support to them because of the stress that they're going through. Their inability to speak, eat, move, and breathe normally. They can also be suffering from pain, fear, and anxiety related to the tubes, the machines, and the ICU setting. Ordinary ADLs are complicated or impossible for patients, so we want to make sure that we're meeting their needs. Patients have identified 4 needs. They need to know, so they need information, need to regain control, so we want to give them as much control as possible, the need for hope, and the need for trust. Please do remember when you're caring for patients on mechanical ventilation that even if they're sedated or on medication to paralyze them, it doesn't mean that they can't hear you. So be kind and be professional when you're in the room with them, and involve patients in their decision making, encourage hope, and build trusting relationships with the patient and family members. Also provide sedation and analgesia to facilitate optimal ventilation. So sometimes that means a little more sedation, or if we're trying to wean them off and we're giving them less sedation, we may need to restrain their arms so that they don't pull their tube out. Again, remember that our paralyzed patients can hear, see, think, and feel. For psychosocial needs and assessment, the Train of 4, the peripheral nerve stimulation, is used. Physiological signs of pain and anxiety should be noted, and ventilator synchrony. This talks about our different alarms. So we have a low pressure alarm. It's the most frequent site for disconnection is between the tracheal tube and the adapter. So if a patient has become disconnected from the ventilator, it'll alarm low pressure. You want to pause those alarms during suctioning or removal of the ventilator and reactivate those alarms before leaving the room. We may have a machine malfunction if we have a loss of power or failure of oxygen supply. If we're unable to locate the problem immediately, we may have to disconnect the patient from the ventilator and manually ventilate them with 100% oxygen using an ambu bag. Positive pressure ventilation and hypermetabolism can contribute to inadequate nutrition. If a patient is likely to be without food for 3 to 5 days, we will want to begin a nutritional program. Poor nutrition will contribute to a decreased muscle strength. Inadequate nutrition can delay weaning, decrease the resistance to infection, and decrease the speed of recovery. Enteral feedings via small bore feeding tube is preferred method to meet caloric needs for ventilated patients. Verification of feeding tube placement is done by X-ray before the initial use and marking the ongoing assessment of the tube's exit site. Ongoing review of routine X-rays and weaning from PPV and extubation process. This process we want to do when there's a decreasing need for ventilator support and when a patient can resume spontaneous ventilation. For a patient to be weaned off of a ventilator, they must have adequate muscle strength to maintain respirations. Weaning from PPV and extubation will differ from patient to patient. Some will require just a short-term ventilation versus long-term. The pre-weaning assessment again determine if the patient's ability to breathe spontaneously, assess muscle strength and endurance, minute ventilation and rapid shallow breathing index. The lungs should be clear on auscultation and on chest x-ray. Non-respiratory factors that you want to assess prior to beginning the weaning process is neurological status, hemodynamics, fluid and electrolytes and acid-base balance, nutrition and hemoglobin. Medications should be titrated to achieve comfort but not excessive drowsiness when you're trying to wean the patient. Weaning readiness. There are guidelines that recommend a spontaneous breathing trial. A spontaneous breathing trial should be at least 30 minutes, but not more than 120. We can do this by putting them on CPAP, low levels of pressure support, or a T-piece. If the patient is tolerant of the trial, they may be extubated. Failure of the trial requires to search for reversible factors and returning the patient to the ventilator mode. Monitor the patient for tachypnea and tachycardia. Also monitor the patient for dysrhythmias, desaturation below 91%, hypertension, agitation and anxiety, a sustained tidal volume below 5 mL per kilogram, and changes in level of consciousness. The standard approach for weaning or weaning protocols have shown to decrease the ventilator days. Patients being weaned and families should be provided with explanations regarding the weaning process and what to expect. Weaning outcome phase. When the weaning stops and the patient is extubated, weaning is stopped because no further progress is made, or after extubation, encourage the patient coughing and deep breathing. The pharynx should be suctioned as needed. Patients may require supplemental oxygen and nasal and oral care. You want to monitor their vital signs, respiratory status, and oxygenation following extubation within 1 hour or by your institution's policy. You also want to make sure that you have intubation equipment and a ventilator still close by until the patient is past that initial period. Some concerns that patients may have after they've weaned from the ventilator is financial issues or caregiver issues.